Hello, good day to everyone. My name is C.B. Mammaril, and on behalf of Systems for Action National Coordinating Center, I'd like to welcome all of you to today's Research in Progress webinar on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. We have a great topic for us today on implementing a culture of health among Delaware's probation population. Before we get started, though, I'd like to first acknowledge the funding and support of the Robert Wood Johnson Foundation. Systems for Action is a national program office of the Robert Wood Johnson Foundation and a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business Economics, administered here at the University of Kentucky. I'd also like to encourage everyone who's joining us today that if you do have any questions about the presentation that you'd like to direct to our presenters or even to our commentator, please do fill out your questions or type in your questions in the chat box at the lower left-hand corner of your screen. So that's the chat box in the lower left-hand corner of the screen where you can type in your questions. So for today's agenda, we will first introduce our presenters and our commentator for today. And if we have any questions from the audience, we'll get to that at the end of the webinar. So let me begin by first introducing our presenters, starting with Dr. Daniel J. O'Connell, who is a senior scientist with the Center for Drug and Health Studies and assistant professor in the Department of Criminal Justice at the University of Delaware, where he teaches criminology. Dan's research specialties are research design and methodologies, intervention development, and project management. He is a principal investigator of this Robert Wood Johnson Foundation project aimed at improving access to health care among Delaware's probation population. His other projects center around improving evidence-based practices in correction and law enforcement. His publications include articles on drug treatment, prison management, HIV prevention interventions, program evaluation, and criminological theory. Our other presenter is Dr. Christy Visher, who is director of the Center for Drug and Health Studies and professor of sociology and criminal justice. He is principal investigator of the NIDA-funded Collaborative Criminal Justice Drug Abuse Treatment Studies, which studies organizational strategies for improving the implementation of evidence-based practices for substance abusing offenders as they leave prison and return to the community. Prior to joining the University of Delaware, Christy was principal research associate with the Justice Policy Center at the Urban Institute in Washington, D.C., where her work included Returning Home, which is the title of a longitudinal study of men and women released from prison in 4 states. Her research interest focuses on communities and crime, substance use, criminal careers, the role of social factors in criminal assistance, and the evaluation strategies for crime control and prevention. Christy has published widely on this and other topics in numerous social science journals and co-edited Prisoner Reentry and Crime in America. Our providing commentary for today's webinar is Dr. Christopher Maxwell, who is professor in the School of Criminal Justice at Michigan State University. He is a member of Michigan State University Center for Gender and Global Context. He is also a faculty associate at the University of Michigan's Institute for Social Research and an honorary senior research fellow at Cardiff University, Wales. His research, scholarship, and engagement activities largely focus on understanding and improving how governments and non-governmental organizations can prevent and control intimate partner violence and violence against women. His sponsored research projects include several that have examined the benefits and costs of sanctions and therapeutic treatments for spouse abusers, the impact of police and court justice services on victims and perpetrators of intimate partner violence, and other projects that have measured the epidemiology and control of violence, including sexual assault by intimate partners. His current program of research focuses on assessing the extent to which partner violence offenders are prosecuted and convicted, and testing whether or not more prosecution and sanction leads to less violence. Chris currently serves as a co-investigator of the National Institute of Justice-sponsored evaluation of the U.S. Department of Justice Office of Violence Against Women Domestic Violence Homicide Prevention Initiative. So with that, I'd like to turn it over to our presenters, Dan and Christy. You have the floor.
Thank you very much, and thank you for having us. Welcome to everybody. I want to start by thanking Chris Maxwell for agreeing to be our discussant today, our commentator. and all the folks at RWJ and the University of Kentucky. So this project is kind of it was born out of conversations we had here in Delaware. We are the Center for Drug and Health Studies. We do a lot of health research. We do a lot of corrections research. And this was kind of an attempt for us to cross the streams, if you will, and to see if we could improve health outcomes for criminal justice involved individuals. And so let me walk you through these here. Here we go. Anybody who knows me knows that I'm a big fan of change teams, local change team efforts, working with organizations and across organizations to attempt to improve practice or expand practice into new areas. And so what we did to try to attempt to improve the health outcomes of justice-involved probationers, we did a change team approach. We got the folks at the Department of Corrections to agree to work with us, and we kind of sent emails around to a bunch of folks, and we brought a team together to attempt to increase the access to health care. We met regularly through the first year of the grant, a lot of time talking about the issues. We were fortunate enough to be able to access some probationers and kind of talk to them early on, or people that had been on probation in the past. As a result of the change team process, we came up with a number of things that we thought we could use to get more probationers to access care. So the real thing we were trying to do was you have people in a probation office. I don't know if you've been to a major probation office, but they're big places. They're busy. There's a lot of people going in and out. And this is a recognized at-need population, a population that perhaps is not accessing care at the level that maybe they could. And so we kind of had a three-pronged strategy of how we could, let's see if we can get these people to the doctor. And I should mention we were working with we were working with some federally qualified healthcare centers, especially in the beginning. We were working with Christiana Care Health Network, which is the largest health network in the state of Delaware. They have 2 hospitals in Newcastle County. And have their tentacles, if you will, throughout the state. So they're kind of the go-to place if you live in Delaware for healthcare. We also had the Division of Health. The Health Department was with us. A couple of local community treatment facilities. So we had a number of different folks that were part of this team. And one of the things we talked about was getting people, was increasing motivation. And towards that end, we actually placed a TV in the waiting room at the probation office, and we recorded or downloaded a number of health-related videos that talked about the need for testing, the need for regular health care. We tried to be as culturally competent as we could with these. We also put posters up on, the regular screenings men should have, regular screenings that women should have. And so we tried to create an atmosphere in the probation waiting room that was a little more conducive to thinking about health, so that when we went out and tried to talk to people, that maybe their minds would already be working that way. We also created something called the Healthier You Workbook. Basically, we got the basic healthcare information written in a real straightforward way, an easy-to-use kind of thing that you could sit there and kind of work your way through. Talked about the need for screenings and the types of screenings and how and where to go get them. It covered physical health, mental health, a host of things that were health-related, and we made that available to people. And then we placed a health navigator, who happens to be sitting right next to me, Judy Buchanan, in the Cherry Lane probation office to link people to health care, largely to the Christiana Network. And so this then became our RCT. We did a pilot kind of randomized trial to kind of test whether you would get more impact placing a health navigator in a probation office than you would giving the workbook. Like, was it enough to just hand people information and, you know, kind of say, hey, you really ought to take a look at this and go to the doctor? Or were people more likely, if you could sit down with them, do a brief kind of conversation with them, and pick up the phone right there in that meeting and call and make an appointment to get them there? So we tested this through a randomized controlled trial, how this would kind of work. So let me advance slides here. I'm not advancing. Oh, I'm hitting the wrong thing. So the hypothesis then we're working on is, you know, HO is screening and referral of probationers by an on-site practitioner will lead to greater proportion of probationers accessing services compared to those receiving the interactive workbook, and H1 then is that it will not lead. So we're testing the workbook against the health navigator, and the outcome variable here was that you presented and kept an appointment with a primary care doctor, a family doctor, if you will, primary care, and that's kind of where we were going. So the design was a 2x2. We randomized 400 people into condition 1, condition 2, the workbook only condition, or the workbook and the practitioner. So the people that saw the health navigator also got a workbook. So everybody got a workbook. So we're testing the addition of that meeting with the health navigator. Data was electronic health records. We were supposed to get Medicaid data, but we didn't. I'll talk about that briefly later. And treatment access from agencies, which it turned out not many people went to. We also conducted a survey of everybody that we screened in. So anybody that agreed to talk to us, the first thing we had them do was fill out a brief survey about some health-related issues. We followed up and interviewed a small sample of people to talk about barriers and facilitators of getting to health care. And that was kind of our design. So off we go. Here are some design slides. I'll just walk you through this because I like the visualization. So if you follow the kind of arrow thing here, I'm going to highlight these as we go through. So you have randomization, and then you have the condition up at the top, the culture of health work group going through here. So 200 folks there, and you would get that, and then you would meet with the health resource facilitator. And given an appointment at a health facility, that was compared to the workbook-only condition, in which case you were randomized and given a workbook. And when we gave them the workbook, it was like literally less than a 1-minute speech. It was kind of like, here's this workbook. We suggest you take a look at it and maybe see about following the advice that it gives. Subsample was each was selected for the qualitative interviews, and then we had 200 each in records follow-up for the outcome variables. And then again, the outcome is the clients present for an appointment with a healthcare facility. Pretty standard design stuff. It's no clusters, no strange stuff like that. Anyway, so we realized very on that we were not getting kind of the effect that we wanted in either condition that we could tell. Like folks were making appointments and not keeping them. What we found, people were totally willing to talk to us for the most part. They were willing to talk to the health navigator. They were willing to talk about their health needs, and often they were willing to make the appointment. What often happens, though, is that they did not keep the appointment. And because we were in the probation office week after week after week, we were able to talk to people. The navigator, Judy, and our research associate, Tricia Becker, were up there. And they would grab people and say, hey, we made you the appointment. What happened? And with this clientele, things get in the way. I couldn't get child care. I thought I had coverage and I couldn't. I thought I had a ride and it fell through. My boss called me and I had to work that day. And these are people that can't turn down work. And so a number of things got in their way. And so we tried to work through that. One of the ways we worked through that was to reschedule appointments. But we also said, what if we dangled out some kind of incentive? In the original Systems for Action call for applications, actually one of the things you could apply for was to test the use of incentives. We did not do that in this, but we did a little bit because the change team we went back and we said, this is how change teams work, by the way. If there's an issue or something happening, you take it back to the team, you work through it. One of the things was suggested, could we give a small incentive? So we devised an incentive of a $30 gift card for people who kept an appointment. And so we said, okay, why don't we do this? Why don't we kind of restructure the thing to go and do this way? And I was going to just change the arms of the study. And then it's the good thing, one of the nice things about these Robert Wood Johnson projects and other projects is we all get together occasionally to chat at some conferences. And I found myself in Austin, Texas, and I was actually talking to Chris Maxwell, who's our discussant, and he said, no, don't ditch the arms you've got going because you don't know that you won't get an effect later. Rather, re-randomize within. And I said, Chris, that's going to be a real pain in the butt. But we did it. We did it. So we added a randomization. So to go back to the slide here then, so we randomized once with each group, and then within that group, each arm, we randomized again. And what we did was we offered 75 people the incentive. 125 people were not offered the incentive. The arms are unbalanced a little bit because we had already randomized a fair number of people, and so we let them be unbalanced. So we added that layer of randomization to the thing. Now, having told you all that, I just in the little pre-meeting we had before this, Chris said, "Where's the incentives data?" And we haven't analyzed it yet. So I want to tell you that before I get to the things. We will not talk about the outcomes on that yet because we have not had an opportunity to analyze it. So that's the study. That's what we did. So what did we find? So we randomized 403 people, 192 to the culture of health condition, 208 to the workbook condition. The EARN was a little unbalanced at the end, but we were okay, and we've run a bunch of checks on it. The samples were the same. 73% were male, and 66% were minority, which is fairly reflective of the population that is in that particular probation office. So I'm going to talk about two outcome things because really we had two major data sources that we were working with here. The survey that all 403 people got, so we have survey results from 403 people, and the pilot trial results. I'm going to talk about the survey results first. So basically, we asked basic health-related stuff. This is a very short survey. It was like 2 pages. So we didn't have a whole lot of room. And it's, as with most people, when you ask these types of things, they generally consider themselves healthy or very healthy. This was not surprising. We asked them if they had a primary care doctor that they see regularly. 44% said yes. Was actually a little higher than I thought going in. I wasn't really sure, but that's what the data kind of told us. So we have 55% of people who did not have a physician going in. We asked them reasons for not having a primary care doctor. Our Christiana Care partners were very interested in some of this kind of stuff, and the reason for that we'll talk about in a minute. Is mostly because they go to the emergency room, but we'll get to that because we asked them. But the reasons were they don't know where to find them. The main one, 33% of people said they weren't really sure how to go about going to the doctor. It's not something that they did in their family. Their families didn't go to the doctor. And the whole idea really of having a general care physician was not something they had thought about. And so we look at this as an opportunity. Because if it is a matter of people not knowing, that is something we can change in future studies and future projects. Transportation was an issue, and you can just kind of work down these, time constraints, costs. No insurance in 19% or 20% there. So between not knowing how to find one and not having insurance, that's over 50% of the folks selecting that as the reason they didn't have a doctor. And so, and then we asked them, have you been told by a doctor that you have any of the following? And what you see here among this group is that these are largely behavioral and mental health issues. Depression was big, anxiety, PTSD, bipolar. So these are not so overly physical ailments that these people are facing. Rather that it's just kind of more behavioral kind of stuff that they need assistance with. Here we go. We asked them the usual source of medical care, and yes, 50. There's a little discontinuity between two of the survey questions, but we often have that. So 51% then said they had a primary care doctor on the specific question, but the one that jumped out at us here was that 28% of them are using the emergency room as their general health care. So when they get sick, when they get the flu, when their children get sick, they're not calling a doctor, they're going to the emergency room. This was of great interest to our Christiana Care partners because they are very busy up in that emergency room, and they would like as much as possible to get non-emergency kind of stuff to not show up there. And so that is what it is. So we asked about health insurance, and about 69% had Medicaid. And then the others, some had it through work, some had it through family. But the vast majority of folks here had their health insurance through Medicaid, and 18% said no, which in the Affordable Care Act days is something that could be worked on. That's another opportunity. We talked about this in our meetings, that perhaps getting some more facilitators in there to work on getting people access to Medicaid would be something that people would be interested in doing in these types of projects in the future. All right, so I'm a criminologist, and I'm always interested in violence and other types of things. So we said early on, hey, if we're going to survey 400 probationers, let's take a look at PTSD with this population, because those of you who may not be familiar, the Cherry Lane Probation Office is the probation office that serves the city of Wilmington. And the city of Wilmington has been going through an epidemic of violence over the past 5-10 years. Actually got better last year. We'll see if it's a blip. But there's a tremendous amount of shootings and violence going on up there. And we had the funny feeling that it was impacting this particular population. And so we added a brief 4-question screen onto the survey that asked about PTSD. So the setup question was, has anybody you ever know been injured by gunfire? And these numbers are off the charts, at least to a person such as myself. Where you see 29% have had a family member injured by gunfire, 25% of close friends, 17% someone in their neighborhood, and 9% actually had been injured by gunfire themselves. So extremely high. These are markers that apply, by the way. You could be in multiple categories here. So extremely kind of high rates of exposure to violence among this group. Then what we did, we filtered on this, and if you responded yes to any of these, we filtered you in and asked these screens here. So if you answer yes to question 20, please mark below. And there's a typical screen that we pulled. So have you had nightmares about it, tried not to think about it, or went out of your way to avoid situations? Were you constantly on guard, watchful? Felt numb, detached from others' activities and things. So, and the results of that question are right there. So 41% of those who had experienced gun violence exhibited 1 or more, 13% 2 or more, 8, and you can just read down through there. And on this particular screen, if you clicked on 2 or more of those, you were suggested as a possible victim of PTSD. And so we think those rates are pretty high. And it's another thing that projects like this may be able to do something to address in terms of referring people to appropriate care. So the key findings from the randomized trial were we had 403 people. We got 80 of them to a doctor's appointment. Quibble whether that's good or bad. We thought that was okay considering the population. And so examining then the data by condition, 45 persons in the treatment condition attended a doctor's appointment, 35 persons or 17% in the control. So there's a slight difference happening there. It wasn't quite significant. Chi-squared test was 0.09. And depending on where you like to draw those lines, I'm a 0.05 guy myself, so, to me, we didn't quite get there. But going back to the survey, we said, well, a lot of these guys and gals had doctors going in. So what happens if we just look at the people who didn't have a doctor and see what happens there, right? And so, 55% of the individuals screened already had a general care physician. So we selected the 176 people that didn't, and it turns out of those, we had 26% in the treatment condition attended the doctor's appointment compared to only 10% of the individuals in the control group. That difference was significant at 0.01. And so one of the things we were talking just before we came into the public room for the webinar was that, in future projects, what we'll probably do is screen into only those persons who do not have a primary care physician to spend the resources and the time meeting with a clinician in these types of studies. So live and learn. That's why we do studies, right? So challenges. For the data people, for me, one of the main challenges was that our Medicaid people kind of decided that they really didn't want to give us the data. They cited a number of issues for that, but it was the lesson to be learned here would be get an MOU because we were told we would get the data, and then it turned out some people changed in some of the positions in the Medicaid office, and they said, well, yeah, we're not going to do that. We don't think this is that big of a deal in terms of analyzing the outcomes, however. We're convinced that having the Medicaid data would not have impacted the outcomes, as almost everybody that we know of and people in the state of Delaware utilize the Christiana Care, and that's where we ended up getting our data from. So some lessons learned. Correctional organizations are willing to coordinate with health organizations. At first we weren't even sure that our Department of Corrections, the probation people, were going to be interested in this. But we went to them and they're like, yeah, we'll try it. And then once they got to sitting around a table with the healthcare people were all in, by the way, because they understood the population. And so we've demonstrated that you can do this kind of work. People are willing to attempt these types of progresses. Second one there, health care organizations and health agencies are willing to meet and cooperate with other entities. So, we live in a siloed world often, but the change team approach enabled us to kind of chisel away at some of that and to offer some ways of proceeding. So, we feel the pilot study demonstrated proof of concept here. Like I said, this wasn't a huge sample. There are some things we are going to do differently moving forward as we try to replicate this. But we have shown that placing a health mentor in a probation office significantly increased the likelihood of a probationer attending a healthcare appointment, which is what we are trying to do. So we didn't follow beyond that because basically it was a short study. We wanted to see if we can get them there. In future work, we may see about whether we can keep people engaged once we get them engaged. Our last meeting we had was in December, actually, and the entire conversation around that meeting was about sustainability. The grant paid for the health navigator to be up at the probation officer. Now that the grant has ended, we don't have money to pay Ms. Buchanan to be up there doing the work that she does. And so resources are not generally available currently to maintain. And so these results indicate a couple of things I'm going to talk about. So on the one hand, the on-site mentor is preferred, but we did see that like kind of creating that atmosphere in the waiting room with the TV monitors and some of the videos and things, and then providing some people with some workbooks and stuff. And the key to that, of course, is very clear instructions of, if I wanted to see a doctor, what are the steps I take? What do I do? How do I get there? And that worked for some people, right? So, what did we have there? 35 out of 200. Those numbers aren't great. but 17% they did engage with a healthcare provider. So for the low cost of putting something like that together, you do get some kind of an effect. And in the qualitative interviews especially, Tricia Becker has been working on this, we're finding that just as involved people, so they're exercising agencies here. So when armed with the resources in the health workbook, may be more accessible and easier to understand, 8th grade reading level, those types of things. Other than the resources that are out there, websites and things like that can be difficult to navigate, individuals in the study were able to access primary care and specialty care services. So meeting people where they are, really, like, even if it's just in a literature kind of a way, and really thinking about the audience and these types of things. It's not that they don't necessarily want to go, but when they were armed with that workbook, a fair number of them did make it to where they were going. Last steps and possibilities, is trying to maintain this in probation. We're working with our Department of Health to set up healthcare screening in probation. Like I said, we had a meeting in December. We're going to have another one in February because people are very interested in sustaining. Here's the thing. We have the room up there, and we're not giving it back. We have an office in probation, and possession is 9/10 of the law. So something is going to exist in that room related to the culture of health. UD is backing out at this stage, and we're willing to assist with people. But these state agencies are stepping up. We are in conversation with Christy and Care. As a matter of fact, Tricia Becker got a call today. They want some of the ER data from us. When we got the data, we checked emergency room usage for the entire sample. Unfortunately, it came in as a huge text field with a series of dates. And Tricia is going through that right now just to get a count of the number of times these folks have been but using the emergency room in the last 5 years. But just eyeballing that field, it is really astronomical. And so Christiana is looking to get resources to put a health navigator up there on a part-time basis. So that's one of the first steps. The Department of Health is looking to provide some resources. They want to provide HIV screening and perhaps HCV screening in that room. And here's the thing about the change team and what the culture of health has done by having these conversations over a 2-year people. Department of Health has wanted to do HIV testing in probation for years, and the DOC has not really been willing. But having worked through this, having people at the table ongoing, Bob Vela is our HIV representative here for the Department of Health that was part of this team. And the conversations just week in and week out working with those folks, DOC is now willing to let them come in here and do that. And so we're working through how to do that. We're going to try to leverage additional funding. First thing Chris said to me when we got on the phone is, what are you doing for replication? How come you're not moving on this? And we plan to, so we're getting there. And so we view, like I said, we view this as a pilot study that demonstrated proof of concept. There were some lessons learned along the way, both from a research end and from a practitioner end, but we definitely think that this can be done, and we think it can be done better. Some of the stuff we learned, we think that the next group, whether it be us or others, that does this, if they learn from us, can hopefully take this model, implement it, and increase the access to health care for this population, because it's a group of people that needs it. The resources are available on the health side. It's really just a matter of educating, linking people, and getting that kind of stuff done. And I think I finished, if I'm correct, about 4 minutes ahead of where I was supposed to be. So that is all I have. And our end slides here are, whoops, I went too far. There's the upcoming webinar. I'm going to hand it back.
No worries, Dan. Thank you, Dan and Christy, for your presentation. Before I turn it over to Chris for his commentary, I'd just like to remind everyone that if you do have questions about the presentation or even to our discussant, please do type in your questions in the chat box in the lower left-hand corner of your screen. So with that, I'd like to turn it over to you, Chris, for your comments and discussion.
Well, thanks, and good afternoon to everybody from a very cold and snowy Michigan. And so I first want to start out by congratulating Dan and Christy and their team for successfully implementing an RCT in a criminal justice environment. They're pretty rare events, both experiments and particularly successful experiments. And so the fact that they've been able to do this with the support from RWJ, that's been a great, it's a fabulous outcome in and of itself that they've been able to do this. The fact they got people in organizations, as Dan noted at the end, they weren't sure even when they approached the Department of Corrections whether they would be interested, and it's exciting to hear that they were. To convince any people who work in the criminal justice field that you want to randomize something is something that raises many, many eyebrows, and oftentimes I think our experience has been that people begin say with the word yes, I think we can do that, and by the time you explain it to them and start to implement it, it becomes much more difficult for it to be sustained because people get worried about the legal and moral and ethical and public implications of doing an RCT with a criminal justice-based population. So I think that all these things are very positive outcomes, even without knowing the outcome of the study. The fact that they got all this done is kudos to them. Sort of moving on to the study itself, I want to focus a little bit, as Dan and I already started talking about some of the outcomes. I think if you're in criminology, but probably if you're not in criminology, the normal spirit of the world is that nothing works. In fact, there's a famous article that's titled "Nothing Works in Criminology," and the fact that in many instances our experiments have shown not many positive effects. So the fact that Dan has shown that they're right on the edge of a positive effect is pretty exciting. It shows evidence, particularly when they look at the sub-analysis there on people who don't have doctors, that indeed the criminal justice system can nudge not only people through sanctions, but also can nudge people in positive ways through positive interactions. And so it does show and demonstrate that that something sometimes can work in the criminal justice system, and particularly in positive ways. So I'm excited on one hand to see the effect and the significant or near significance of it. I think, as many people might notice, it also leaves the fact that only about 23% are going to a doctor. While that's an improvement over the 17%, still leaves a lot of room for improvement. Why isn't the other 25, 26, 27% not going to the doctor? What are the barriers and ways that the system can facilitate that? What else can be done? So I think there's still lots of room for improvement in both this research base and what we can do, but also the practice. I think, and Dan started to discuss this a little bit. Besides the experiment, there's lots of other data that the folks collected that can both inform theory but mostly practice of this population. So I really encourage the team to continue. I know it's difficult in this environment to do more work without additional support, but so often we spend so much time in doing experiments, and so much energy is expended just to get the study done that so much of the data goes unanalyzed, particularly when the effect sizes may not be as large as one had hoped. People kind of forget the study and move on. And so really encourage, as Dan started talking about, doing some sub-analysis, looking closely at that data. Of course, Dan didn't mention that one of the questions I'd asked him offline was whether they had outcome data like recidivism, lower revocation rates, and what led me to the question is, well, if did the improved healthcare access reduce long-term rates of recidivism and thus long-term cost to the system? And so, that maybe with a larger study, a multi-site study, they can begin looking at how access and usage results in other sort of long-term effects. I now want to kind of switch a little bit and think about some bigger picture issues for folks that may not be aware of probation situation in the United States. So right now there's about 5 million people in the United States that are under supervision in the probation system. That number has stayed fairly constant for the last 5 years. It's a little bit down from where it was 6 or 7 years ago, but still is 4 times more people today that are on probation than there were in 1980. So some people have kind of coined the term we are in a state of mass supervision in the United States when nearly 5 million people are under constant supervision, and particularly under supervision that's almost impossible to succeed. Our colleague Todd Clear and others have noted that the level of supervision, the degree of supervision has not only have we increased the number, we've also increased the conditions of supervision to a point that it's nearly impossible to be successful in supervision. And so I think we are at a state that everybody's beginning to wonder what we're going to do with 5 million, how can we address this? And there's been a beginning to be a push led by a number of people, particularly the Pew Foundation and others, to start to address this supervision issue. And I just did some calculations on the napkin here, and a program like this can begin to address sort of the issues that we've increased the population size dramatically, but we've not increased the services that could help probationers at all. And this program is a pilot program and begins to demonstrate that we can actually provide services that can be beneficial. And so it might begin to sort of nudge us in a different direction. Instead of being a probation is being about supervision, it can be more turning to a focus on probation being a service provision. And if we just look at the effect sizes that they showed up on the screen here a minute ago, without this intervention, if you just expanded this to total United States population, about 850,000 probationers a year probably visit the doctor's office. With this program, actually it would increase the size by 250,000 people. So we just have over 1 million of the 5 million people who would go to see a doctor. So if that 250,000 extra in the doctor's services helped, or healthcare services helped to reduce recidivism, we could significantly sort of start taking a bite out of the problem that the increased supervision just leads to increased incarceration. So I think in the bigger picture, this pilot program provides a positive example of how we can use probation as an alternative to supervision, but more as a service provision. And I hope that, as Dan and I discussed before, that this project can be first reproduced, see if someone else can use these same data to find the same effect, to build confidence that this team has produced a notable finding. If you use the 0.10 level. And then with that sort of increased confidence of benefits, we can begin replicating this in other places. Because as I've noted, if this was taken to the nationwide implementation, it could positively impact nearly 250,000 people in the United States who are under supervision by the criminal justice system. So with those kind of comments, again, I want to congratulate the team. It's great to see what we saw 2 years ago come to fruition when we all started our studies, and it's good to see you guys have been able to accomplish what you intended to do with the delivery of an experiment. And hopefully with some more data analysis, you'll be able to find some positive effects that can support replication other places. So with that, I turn it back to you guys.
Yep. Thank you, Chris, for the comments. And before we turn it over for questions from the audience, I'd like to give Dan and Christy a chance to respond to Chris's comments.
First, thank you. That was really good. I like the back of the napkin kind of analogy of expanding that. As a matter of fact, Chris, I may steal that and put it in the discussion section of a paper because probation does, probation offices in this country see an enormous number of people, and they see them on a regular basis. A lot of these people are reporting weekly, and the ones that aren't reporting weekly are reporting monthly. As a criminologist, I can tell you, these folks have issues. The people do not wind up in our criminal justice system, randomly. So they tend to be folks with a host of issues that can benefit from services, benefit from social services, and so expanding projects like this are very important for us. And Chris, I will send you the data actually to get some replication. Well, I'll talk to you whether you want it, so that we'd like to have somebody replicate our findings, perhaps before we even publish. Might be a good thing to do, because that's becoming a bigger issue bigger issue than this study. So yeah, looking back 2 years ago when we started this, we feel like we've come a long way, and we've got a finding that's interesting and has the potential to be expanded. And so Christy is waving at me and wants to say a few words, so I'm going to let her talk to him.
Well, I just wanted to comment a little bit on what, Chris, you said with respect to the recidivism outcomes. We chose the outcome of whether or not they presented for an appointment because this was a pilot study, and we could not expect that we could do a longer follow-up study within a 2-year time frame. But we know from the reentry literature that health outcomes affect reentry success, and especially mental health problems, which we indicated with our survey data that this population has quite a few mental health problems, and of course now many of them we know are not getting treated for those mental health problems. And those health problems, physical, mental, and substance use problems, inhibit people from fully reintegrating into communities after they are incarcerated. They inhibit them from getting employment, inhibit them from doing other kinds of changes in their lives that will make them successful. So ultimately, we would like to expand this project and look at that cascade from improvements in health to improvements in their criminal behavior and substance abuse patterns. And the theory would suggest that we would see some of those kinds of outcomes in a longer study.
Would folks like me to address some of the questions that have... Oh, go ahead.
It's okay, Dan. I think, we can go to the questions. We've got a few minutes for that, and we can start with a question from Alexandra, who says, did any of the participants talk about the needs for substance use disorder treatment?
Not a lot, and it's something that we didn't necessarily probe on it. Future studies, we did not do a substance abuse screen, but you could have done some of those things. It is actually interesting. I mentioned this project to some folks at our Division of Substance Abuse and Mental Health. As with everybody else, the state of Delaware is in the middle of a rather large opioid epidemic, and the DSAM folks are looking to expand access to services. And so when we kind of like work on these sustainability models, they have stressed that they might like to get in and do some screening as part of this, or maybe develop a screen that one person does. These are the issues we're working through now. What we did get a lot of was people asking specifically about eyes and teeth, so we do the health screening, and Judy talks to them about the need for screening and this and that, and they would ask directly, if I go to the doctor, can they help me with my eyes? Can they help me with my teeth? And of course we said yes, and so those types of things can be built in, and in future studies we didn't screen on that kind of stuff, but you could, which would pique the level of interest even more, I think, for people seeking those kind of services. A lot of people don't. Again, it goes back to the large number of people that said they didn't know how to access this kind of stuff, so definitely expanding into that area as well.
All right. Alexandra also has another question. Can you talk about the probation officer's reaction to the focus on health within the probation facility?
Well, no. No. Here's the thing, and I've seen this with these studies before. Okay, first, the upper-level administration folks were fully on board. We worked with the deputy commissioner. The commissioner was aware, but he didn't come to the meetings. The deputy commissioner came to a few. The bureau chief of community corrections was fully on board with this stuff. They get it. Now, when we get to the level of officers, it was a mixed bag. We had some officers that were very supportive. We have one that actually now comes and speaks in Tricia's class as a result of this study because of the conversations they had up there. So we have some people that were very supportive. We had others that were directly hostile to the people that were in the room, to Judy and Tricia when they were up there. You know, why are you offering services? Why are you taking these people away? You know, they're on my caseload and they're talking to you. They don't need to be doing that. So it was definitely a mixed bag on that. Now we're going back up in February and we're actually doing a direct presentation to the entire PO staff. Up there where we're going to start addressing this. So kind of one of those lessons learned and future things to do would be to work to get the buy-in, to educate and get the buy-in of the PO staff in studies like this. We didn't really think it through and do that in the beginning. You know, we talked to people and we were around and we let them know, but we didn't do a formal mechanism to increase the knowledge of the POs and the buy-in that we got from them. And our recommendation to people doing this is that they should do that. Tricia's waving at me here for a little bit. So,
and I think one of the most important things that we noticed throughout the project was trying to make the job easier for the probation officers. So we found out that if we took an individual back to our office to do the survey, we could bring them then to their probation officer's office to have their meeting after us, or the officer could just interrupt us and take them, and then we would catch up with them later. So we definitely made it accessible for the probation officers that we weren't making their job harder. We weren't taking the people that they needed to see and causing issues with that. So we worked around their schedules and what we needed to do just to make it easier for them.
Okay. So Shauna has a question. Did you have to make any facility adjustments, I guess it's infrastructure-wise, for a healthcare presence in the probation office?
We did not, and this will get to another question that I see is coming below. When we talked about doing some more direct screenings that would involve blood draws, we kind of ran into some stuff because we would have had to put in a safe sink and do some other things, which kind of it helped us focus with the types of things we were going to do. We wanted to do some more direct screening on site. But early in the study, some of those facility changes led us to the health practitioner, the health navigator aspect. So rather than trying to deliver services on site, we went with the idea to go ahead and try to refer people out. Now, again, working with our Department of Health folks to do the HIV screening that they're intending to do, they're not going to do blood draws. They would have to do blood draws if they were going to do the HCV. So those are issues that we're willing that we're going to be discussing. And again, you know, part of what projects like this do is build trust and relationships. So we're not starting from where we started 2 years ago. So in terms of the health department doing some of the HCV testing, which would require some facility changes, we're probably in a better position to be able to address that and allow. We wouldn't be making the ask necessarily. It would be the Department of Health making the ask. And again, like to get back to what Chris said, to moving towards providing a host of services rather than just observation and supervision.
All right. I think that was you're referring to the question from Carolyn about, you know, putting a primary care physician inside the probation office. So you, just to clarify, you said that it was more, you know, encouraging or having these referred out to these primary care physicians.
Yeah, referring those out, and we talked about even having RNs to having nurses in there, and the cost of putting nurses in is pretty prohibitive. So we went with the refer out model. I don't know the refer in model, like literally putting it
much longer than they have to be. So I feel like
right.
Privacy and stuff, they don't want the offices known.
Right. The other thing is privacy concerns and things like that, and when you're bored someday, go sit in a busy probation office waiting room. People can sit there for hours waiting, and they want to get out of there. So we didn't want to try to do anything that involved any more time than was necessary.
Okay. So I guess we have a minute or two for the last question, I think, and I just want to also put in my question that is related to what Alexander's asking, about the economic and fiscal implications from the results in your study. Like you mentioned in one of your slides, and the health needs indicated about 18% of the participants did not have health insurance, and then you also indicated a high ER utilization rate. So, Alexander's question, are any of the healthcare payers involved in this project? Would you think that engaging potential high utilizers of medical services would be of interest to these payers? And I just wanted to add, does the COH work, the Culture of Health workbook and change team framework, does that provide guidance for availing of coverage apart from, having a navigator on hand too as well?
Yeah, to work backwards through it, the Culture of Health workbook provided information on if you wanted to get Medicaid, where you would go, how you would go, what the process was for getting that set up. In terms of working directly with payers, we didn't, and it might be something that future studies would want to do. I think certainly the incentives. Christiana Care is definitely interested. They were very honest with us from the very beginning. They're interested in healthcare, but they're also interested in finances. And because they know this population is showing up in their emergency rooms, which are expensive to treat, they tend to show up there uninsured, and they can't really just turn them away. So they're doing a lot of this on their own. There's definitely a benefit there. So to bring in Medicaid and other folks, who are also paying the bills when people show up at the emergency rooms, to do some cost analysis, perhaps to determine whether it might be worth expending some money to put some health navigators in places to try to cut down some of those numbers. So did we do it? No. Should we have? It's maybe. Should we in the future? Absolutely. So I don't know if that answers it, but.
Well, thank you so much, Dan. There's so much more to discuss, so we encourage people, if we didn't get to your questions, or if you do have any questions about the work that Dan and Christy and the research team Delaware have done, please do forward. You can contact them directly or forward to us. Their presentation today will be also available, posted on the Systems for Action website. So we do invite you to take also a look at that if you are interested in downloading this webinar too as well. And we'd like to thank you, Dan and Christy, again, and also Chris, for your comments and discussion, and for the time that you've had in presenting this webinar. We thank you also to our audience for joining us, and we do look forward to have you guys joining us again in the future. And thank you so much again for everyone, and have